Good evening, guys. So today we're going to discuss part two of glomerular diseases. So today we'll discuss glomerular diseases part two, and today my focus is going to be nephrotic syndromes. So last time in last class we started off with glomerular disease. I told you how you have to approach it in terms of primary and secondary, and I told you how you have to approach it in terms of syndromes. So whether it's a nephrotic, or an RPGM. So last time we discussed few diseases about nephritic, we saw about IRGN mainly, we saw about lupus nephritis. Yeah. So today we'll discuss about nephrotic syndromes. So the first thing is about definition. You may get some fact-based MCQs regarding the definition of nephrotic syndrome. So I've really not put an MCQ, but I've just put this slide. This is from the KDIGO guidelines. So in these topics, be it NEET SS or any SS for that matter, you may get some questions from the KDIGO guidelines as well. I'd already mentioned that. So what are the salient things that you have to note? We already know about the definition in adults. It's more than 3.5 gram of proteinuria in a day, 3,500 mg. And in children, we already discussed that last time. It's more than 40 mg per hour per meter square. Yeah, that's something that you have to know. And or 3 plus on a urine dipstick if you don't have the 24-hour collection, or more than 300 mg per deciliter, or a PCR more than 2. So here there's a small difference. If you look at the PCR in adults, if you look at the PCR in adults, it's greater than 0.3. In children, it's greater than 0.2 milligram per gram of creatinine. So that's a difference that you have to appreciate. A lower threshold for nephrotic syndrome definition in pediatric age group. So more than 0.2 is nephrotic syndrome in children. More than 0.3 is nephrotic syndrome in adults. And apart from this, we already discussed about the pentad. You should have hypoalbuminemia, edema, hyperlipidemia. Yeah. So those are the things. And there are two other terms that I want you to be familiar with. One is nephrotic range proteinuria. So here you have the same definition with regards to proteinuria, but look at the last table here. I want to draw your attention to here. The serum albumin is usually normal. Edema is usually minimal or absent. And the lipids are normal or just mildly elevated. So that's the thing. There is a nephrotic range proteinuria. So this happens in diseases where the disease has been going on for quite some time. The onset is not abrupt. It's been going on for quite some time. So the body has gotten time to get adapted to it. The liver has increased its production of albumin by upregulating the synthesis of albumin despite the loss. So that's why albumin is usually normal. And because albumin is usually normal, the oncotic pressure is maintained and edema is minimal. That's simple. And then you have non-nephrotic range proteinuria, where your proteinuria is lesser than the nephrotic range. So these three terminologies you have to be familiar with. Is your patient having nephrotic syndrome, where he has proteinuria and low albumin? Main thing. With or without edema. If edema is there, well and good. And to complete the pentad, he can have hyperlipidemia and lipiduria as well. And nephrotic range proteinuria, the diseases that have been there for quite some time and are being detected after quite some time, there the albumin is usually normal and therefore edema is minimal, but the proteinuria is nephrotic. Okay, and then you have non-nephrotic range. Now here one more thing, one more difficult MCQ that can come. So just put a look at the footnote, whatever is written. Okay, they have recommended methods to measure the serum albumin. Okay, methods to measure the serum albumin. There are different methods of measuring serum albumin. So that's the difficult MCQ that you can get. So the first MCQ for today, which of the following is the least accurate in measuring serum albumin level? So this is a slightly tough question, probably something that you don't expect in NEET SS exam because it's not really Harrison based. But which of the following is the least accurate? Can I get one answer so that we can go to the discussion? Okay, so you saw it in the footnote probably, but good if you already know it. So bromocosol green is the least accurate. Okay, it is the least accurate. The other methods are recommended for this thing. So around 0.5 gram per deciliter difference will be there. Okay, around 0.5 gram per deciliter difference will be there. Okay, so for example, that is why the cutoff is more when you are using the BCG method. Okay, the cutoff is more when you are using the BCG method for nephrotic syndrome and less when you are using the bromocresol purple or capillary electrophoresis or the immunonephrolometry. Okay, so bromocresol green overestimates your albumin. It shows a higher value than actually there is. So the cutoff is also more. Overestimates albumin level. Okay. So 2.5 in BCG means 2 in bromocrazole purple. That 0.5 difference you please remember. Okay, for example. And why does this happen? Why does bromocrazole green actually overestimate albumin? Because it has interactions with other proteins, specifically the alpha macroglobulin. So that's the only point you have to remember. You have to remember that bromocresol green is a less accurate method. Doesn't mean that you should not use it. For example, in our center, in our biochemistry lab, it is the BCG method that we use. Okay, but we have a higher threshold for diagnosing the albumin, low albumin. So when it is less than 3.5, then you take it as low albumin. Whereas when you use the bromocresol, so BCG 3.5, less than 3.5 is hypoalbuminemia. When you're using the bromocresol purple, less than 3 is hypoalbuminemia. Okay, to put things straight. And bromocresol purple is accurate. There is no interaction with the alpha macroglobulates. So that's one point you have to know. Second question, because we're going to discuss about nephrotic syndrome, I wanted to understand that this particular cell called the podocyte is at the center of everything. So this is a question which I got in my AIMS exam when I wrote a few years ago. So which of the following is not a primary podocytopathy? Not a primary podocytopathy. You have four options: minimal change, FSGS, DMS, diffuse mesangial sclerosis, and membranous nephropathy. Somebody's told D. Amit says B. One more answer and we'll go to the discussion. One more. Another B, another C. Okay. So the question is primary podocytopathy. Okay. Primary podocytopathy, which means the problem is in the podocyte itself. Okay. There is a problem with the podocyte itself. That's obviously the meaning of primary podocytopathy. So MCD and FSGS, no doubt, are primary podocytopathies where you have problem in the podocyte itself. And the confusion that you may have is between C and D. So C, or diffuse mesangial sclerosis, is nothing but a histological pattern that is seen in patients with congenital nephrotic syndrome. Okay? Congenital nephrotic syndrome. They occur pretty early, like by birth or within the first year of life. They have nephrotic syndrome that's not going to respond to any kind of treatment. And within the end of the first decade itself, they reach ESRD. Okay, they have a pretty bad prognosis. Your NPH has one mutation, which is in nephrin. Okay, or sometimes the NPH2 mutation, which is in pyrosin. All this causes the histological entity of diffuse mesangial sclerosis. Okay, it's a form of congenital nephrotic syndrome where there is a mutation in the podocyte proteins, the slit diaphragm protein specifically. So that is also a primary podocytopathy. You have only three primary podocytopathies, that is minimal change disease, focal segmental glomerulosclerosis, and DMS, or diffuse mesangial sclerosis. Okay. Membranous nephropathy, on the other hand, is a secondary process. Okay, it's a secondary process. We'll discuss about membranous nephropathy in the coming slides. So podocyte, I just want to tell you a couple of things about podocyte. So podo basically means foot or foot-like. So that's the essential thing about podocyte, isn't it? So you have a huge cell. So among the three cells that are there are three types of cells in the glomerular tuft. One is a mesangial cell, the other is an endothelial cell, and then you have your podocyte. So the most abundant cell is the mesangial cell. The endothelial cell comes next, and the podocyte is the least frequent. 3 to 1, a ratio of 3:2:1 for mesangial cell, endothelial cell, that is the capillary lining endothelial cell, and the podocyte. So podocyte is a huge cell when you compare it to the endothelial cell and mesangial cell, and it has a large cell body. It has primary food processes. Yeah, lot of food processes that come from it, and then from there you have secondary food process also. You have secondary food process also. Large cell body, primary food process. You can see it in this diagram. This is a beautiful scanning electron microscopy diagram. I'm going to tell you something about electron microscopy. Scanning electron microscopy gives you a very beautiful 3D image of anything, any microscopic thing. So this is a 3D image of a glomerulus. So you can see the capillary loop, which is almost totally covered by the podocyte. So you can see the interdigitating process. Yeah. So the violet that you see is the capillary. Yeah. The capillary and the GBM. Capillary, which is covered by the endothelial cell and the glomerular basement membrane. And the blue that you see, the turquoise blue that you see, is actually the podocyte and its food process. So you can see how magnificently the structure is. Okay. And podocyte is very, very important part of the filtration barrier. That's what I wanted to understand. So podocyte is a derived cell from the visceral epithelial cell. So in the glomerular tuft, you have the Bowman's capsule, which is the covering of the glomerulus. And the Bowman's capsule has two types of epithelium. One is the visceral epithelium, the other is the parietal epithelium. And the visceral epithelial cell is what gives rise to the podocyte. So the third point is it's a terminally differentiated cell. It is a post-mitotic cell. So if a podocyte is lost, it is lost forever. That is a very, very important thing that I want you to understand. If it is lost forever. Okay, new theories are coming up about regeneration, but don't get confused. Podocyte is a terminal differentiated cell. It does not regenerate. Okay, it's like a neuron. And this word you have to be familiar with. Perm selectivity. Perm selectivity is the ability of a cell to differentiate between anion and cation. Okay, so perm selectivity means charge selectivity. You know that the filtration barrier filters allows or does not allow substances based on two things. One is size, the other is charge. So perm selectivity is the technical word for differentiating cations and anions. And podocyte, what are the functions of podocyte? So it maintains the structural integrity of the glomerulus. It helps in remodeling of the glomerular basement membrane if there is any injury. And it also secretes a lot of trophic factors, your vascular endothelial growth factor, VEGF, your platelet derived growth factor, PDGF, all comes from the podocytes. So they are very important trophic factors. And endocytosis of filtered proteins. Whatever gets filtered is endocytosed by the remaining part. So starting from the podocyte, then it goes into the tubules, your proximal tubular cell, everything endocyte cytoses your filtered protein. So podocyte performs that function as well. Okay. One more point. One more point. Just remind me, because it is a terminal differentiated cell, there is one more important point that I want to tell you. I'll tell you in subsequent slides. Okay. If I don't tell you anything more about podocyte, please remind me. So I hope you understood that. One small diagram just to this. So last time I told you about the transmission electron microscopy. We showed a diagram, isn't it? We showed something in that. I don't remember what figure, but we did show the transmission. So this is scanning electron microscopy. So this gives you more detail. So this is what you do in the EM, the renal biopsy electron microscopy. We do a transmission electron. We get a 2D image. We get a two-dimensional image. We get more detail, more magnification. In the scanning electron microscopy, you get a 3D. You get a beautiful image, but you don't get much detail out of it, like this diagram that you saw. Just some information. So here about the filtration barrier, few figures I wanted to show you. So you can see how beautifully there are three layers. Remember, there are three layers in the filtration barrier. These things are important for you to understand nephrotic syndrome. So you have your capillary endothelium, the line that you're seeing here. Okay. And you can see fenestrations. So the capillaries in the nephron are the glomerulus are very special in that they have fenestrations. You don't have fenestrations in most of the circulations in the body. I think somewhere else, I think somewhere in the bowels and somewhere in the pancreas, you do have fenestrated capillaries, but otherwise you don't have fenestrations in your capillaries, endothelial capillaries. So here you have capillary endothelium. So the diameter is around 50 to 100 nanometers. Okay, 50 to 100 nanometers. So it's a little more bigger. And then you have your glomerular basement membrane, your GBM, okay, which again has a lamina rara interna, lamina densa, lamina rara externa. You can see the words here, LRI, LD, LRE, okay. So just know that there's a GBM, and in GBM you have the equal distribution of negative charges. The GBM is lined by heparan sulfate, lot of proteoglycans, but heparan sulfate is the one that you should remember. This confers the most negative charge to the GBM. There is loss of all this in most of the diseases. So the heparan sulfate, you can see how beautifully it's arranged in a very regular manner in normal glomeruli. And you can see this is some mutation, LAMP2 mutation. So just for MCQ sake, you won't get all this, but Pearson syndrome. LAMP2 mutation causes something called Pearson syndrome, which is again a congenital type of nephrotic syndrome with other extrarenal issues as well. So Pearson syndrome is LAMP2 mutation. So you can see in that how these negatively charged particles are arranged in a not so correct manner. Yeah, heparin sulfate. Somebody's typed. Great, great, very good. Yeah, these are the composition of the GBM, heparin sulfate, laminin, nidogen, collagen type 4. Yes, that's gone wrong in Alport syndrome. So your negatively charged particles are not properly arranged. Some are here, some are not there. So what happens is this sperm selectivity or charge selectivity is lost. Things can get leaked. Things can they don't get repelled. Small stuff get leaked. So that's the problem. That's one thing I want to understand. One more diagram. One more diagram. In this diagram, I particularly want to tell it's a little more nice. So there's a capillary lumen. You have your fenestrated capillary endothelium. You have the GBM. Then you have your podocyte. And then in between the podocytes, you can see this line. Yeah, this is your slit diaphragm. The secondary food process of the podocyte again, this thing by the slit diaphragm. And this slit diaphragm, the diameter of the pores in the slit diaphragm is only 4 nanometers. So you can see how from 50 to 100 nanometers in the capillary endothelial fenestrations, how it becomes 4 nanometers. So there are triple layers, 3 layers, but nothing is actually should be lost. So you imagine what kind of problems occur. And this green is by image. So it shows you the actin cytoskeleton. So when your actin cytoskeleton is getting affected due to so many mutations, for example, ACTN4 is a cause of nephrotic syndrome, FSGS. Actinin, so it affects the actin cytoskeleton. So the podocyte is not strong enough, the scaffold is not strong. So it causes the effacement of the food process and leakage of protein. One more diagram. So what our dear friend Sarthak has put here. So all that is here. Laminin, type 4 collagen, nidogen, heparin sulfate proteoglycans. These are the GBM components. Okay, and you can see your food process and the slit diaphragms. So remember 4 nanometers. Remember 50 to 100 nanometers. Two things that you have to remember. And how the negative charge is so beautifully arranged, regularly arranged. And when that's gone, there's a problem. Actin cytoskeleton problem. Slit diaphragm proteins problem. We discussed about nephrin and podosin. So many areas where you can have issues, and mainly all the issues are the podocyte. That's the other thing I wanted to remember. Whenever you have nephrotic syndrome, when you have more than 3.5 grams of proteinuria leaking, more often than not, you have some problem with the podocyte itself, either a primary process or a secondary process. So this question, yeah. Before that, don't read the question yet. I just want to tell you one more thing. One more thing I want to tell you about the podocyte. Okay. So podocyte may, sir, is that Pearson syndrome or Pearson syndrome? Uh, as far as I can remember, it is PIER only. Okay, you can check it up on Google later. It's not the mitochondrial disorder. It's not the mitochondrial disorder. It's a LAM2 mutation, so it comes with an I. But we can Google it later. Okay. So PIER, Pearson syndrome. So you have two things that can happen with the, oh, it's Pearson syndrome, is it? Okay, we'll verify that. So there are two things that can occur with the podocyte: an effacement or a detachment. Okay, an effacement or a detachment. So effacement is where this food process that is so well interdigitating, that happens. So it's okay. It's PEAR. Yes, my bad. We'll clarify that later, guys. That's least important for you. I'm telling you. Let's not overburden ourselves with unnecessary things. You are never going to see Pearson. I've never seen Pearson so far. Very unlikely, and you can't do anything about it as well. So effacement of food processes means that your interdigitations are lost. There's a lot of gap that is happening, and proteins are getting leaked. So effacement is one thing that can occur, and this is what primarily occurs in your MCD. This is what primarily occurs in minimal change disease. Whereas in other diseases, in any other podocytopathy, you have, apart from effacement, detachment also. The cell itself gets detached from the Bowman's capsule, and then it is freely floating in the urinary space. It is lost in the urine itself. So there is loss of podocyte. And we already discussed that once podocyte is lost, it's lost forever. So in a minimal change disease, because there is effacement, you lose protein. There is selective proteinuria. Albumin is lost in grams and grams. But if you notice, the renal prognosis in minimal change disease is very good. This point I wanted to understand. This is a very special point. I'm telling you, it's not usually mentioned in textbooks. So please understand this. Renal prognosis is very good in MCD, by which I mean that you really don't see a minimal change disease patient going in to develop chronic kidney disease and going in to develop ESRD and being put on dialysis requiring transplant. Never. MCD, that does not happen because the primary pathology is effacement of food process. You lose protein, you give some steroid or some other medication and it becomes okay. It may relapse again. It may relapse again, but it's never going to go into CKD because the other functions of the podocyte, like maintaining the structural integrity of the glomerular scaffold, of contributing to the trophic factors like VEGF, PDGF, all these things are no filtration. The endothelial things is 50 to 100 nanometers. No confusion about that. Okay, so if you have an option of 50 to 100 nanometers, you go for that. Okay, and slit diaphragm is 4 nanometers. Okay, two things. And so your effacement is there. And detachment, when you have your other diseases like FSGS, when you have your other diseases like FSGS, okay, or your diffuse mesangial sclerosis, when you're talking about primary podocytopathies or any other disease which cause podocyte damage, like for example, diabetic nephropathy, here you have detachment of the podocyte itself. So the other functions of podocytes are also lost. And over time, if the proteinuria is unchecked, it will lead to glomerular sclerosis. It will lead to hyperfiltration, injury, glomerular sclerosis, patient develops CKD, and stage renal disease. One fundamental difference between MCD and FSGS. Both are primary podocytopathies, but their renal prognosis are very, very different. Okay. MCD does not go into CKD because there's only effacement, whereas in FSGS, you have effacement along with detachment. Why this difference in pathogenesis is there are for unknown reasons, but you should know this effacement and detachment. Okay. So let's go for this question. So regarding the management of nephrotic syndrome, there are, apart from the treating the proteinuria itself, there are two things that they will ask you. One is regarding management of lipids, and the other is management of anticoagulation. Okay. So you have a 50-year-old male admitted for evaluation of progressive pedal edema. He's normotensive. He is non-diabetic. There is no past medical history. His CUE shows a 4 plus albumin, no RBCs, which means there is an inactive urine sediment. The creatinine is 1.1, which is normal for a 50-year-old. For males, it's up to 1.2 is good. Albumin is 2.7, which means it's low by any method. And albumin, 24-hour urine protein is 8 gram. Renal biopsy is reported as membranous nephropathy. So, what is your comment on anticoagulation strategy, because the venous thromboembolism risk is higher in NS and more so in membranous nephropathy, isn't it? So, what is your comment? So, two of you have typed D, that anticoagulation is not indicated. Less than 2.5 is indicated. Good, good. So, start warfarin, start apixaban, start aspirin, anticoagulation not required. So, we'll have to go to the next slide before answering this one. But the answer is absolutely correct. So less than 2.5 is when you actually have to give. The risk of thromboembolism increases when the serum albumin is less than 2.5, okay, as measured by the BCG method. So when it is more than that, you don't require anticoagulation with warfarin or newer anticoagulants like apixaban. You could still consider aspirin whenever it is less than 3.2. You can still consider aspirin if the arterial thromboembolism risk is high. Okay. So we'll just go to that thing from KDIGO guidelines again. So serum albumin less than 2.5. So they tend to mention it in grams per liter. So that's why the number is 25. So less than 2.5 gram per deciliter, you have to try to give some anticoagulation, but you would assess your bleeding risk. So that's one more point. So suppose your question had an option of assessing bleeding risk, then that's what you have to do. You have to assess your bleeding. Suppose the albumin was 2 in that question and you want to give anticoagulation. The first step is to assess the bleeding risk and see whether the patient has a low bleeding risk or a high bleeding risk. In case the patient has a low bleeding risk, then you can go with warfarin because that's what's studied in the trials. But you can newer agents like apixaban are being tried, but we don't have clinical trial data to support the use of apixaban as yet. So the KDIGO guideline supports only vitamin K antagonist warfarin. And if you have a high bleeding risk, then you don't give warfarin, you can probably give aspirin. Okay, but this part is not going to be tested for you in MCQs. It's this part. Assessing bleeding risk. If low risk is there, go for warfarin. If high risk is there, then you probably prefer aspirin. And when the albumin is slightly higher, but still not normal, so it's less than 3.5, it's less than 3.2, then you have to actually assess their risk of arterial thromboembolism. You have to put the Framingham risk score. You have to estimate their other risk enhancers of thrombosis, like whether they already have CKD, whether they have diabetes, whether they've had a previous thrombosis. And then if you feel that they have the risk of arterial thrombus, then you go for aspirin. But usually, venous thromboembolism is only common in nephrotic syndrome. It's very rare for arterial thrombus. There are only case reports. It's not at all common. It's only venous thrombosis that is common. Okay. So that's the question. So anticoagulation, you have to be clear. Less than 2.5, anticoagulate. But assess the bleeding risk first. Next question. 9-year boy with abrupt onset NSRCA, normotensive bland urinary sediment, which means there is only proteinuria, no RBCs or pus cells. Normal GFR, estimated GFR, the albumin is very low, 1.9. The 24-hour protein is too high, 12.5 grams. And the total cholesterol is 450. The LDL-C is 280 and the TGL is 400. Comment on the lipid profile. So somebody's told lipid is normal for pediatric age. Somebody says start atorvastatin. Somebody says no action is required. So we're a little divided on it. So you have to understand for any glomerular disease, any proteinuric glomerular disease, persistent hyperlipidemia needs to be treated. Okay, that is the take home message that I wanted to. Only persistent hyperlipidemia needs to be treated. Because, for example, this 9-year-old boy, most likely we are dealing with minimal change disease. We are going to start him on oral prednisolone. You expect a good response within 4 to 8 weeks, isn't it? His proteinuria is going to remit and the lipid profile is automatically going to come back to normal. So even if his lipid profile were going to be high for 2 weeks or 3 weeks, that's not going to confer any additional atherosclerotic risk. So you need not treat uh, a altered lipid profile on day one. Okay, you need to treat only persistent hyperlipidemia. On the other hand, if you have an adult already has other risk factors for atherosclerosis and you have a disease which you do not expect to remit soon, for example, they have a membranous nephropathy or a focal segmental glomerulosclerosis, which is going to take a longer time to actually respond to your treatment, then probably you can consider. That also is just like for general population, where you actually try to give lifestyle modifications, weight loss, smoking cessation, diet control, physical activity, and then you go for statin therapy. Okay, it is only then you go for statin therapy. And if anybody is not tolerating statins, then you go for other things like your fibric acid derivatives, your nicotinic acid, or your newer drugs like PCSK9 inhibitors, or your cholesterol absorption inhibitor like ezetimibe. All these things can be given. Okay, so that's the point I wanted to tell you. The correct answer is no action is required. No action is required. Persistent means on regular follow-up. There is no timeline that is given in any of the guidelines, but this is the concept. This is the concept. So on every checkup, you are asking him to come every 1 month to you, and then you do a lipid profile, and then you see it's high, then you can go. Okay. And usually on a clinical practice, when the disease is identified, then for example, MCD, we never treat with statin because you expect it to remit so. Okay. Lipid is obviously high. The ranges are same for adults and pediatrics. Okay. And for a child, always remember, I always used to tell anybody I meet. So for type 1 diabetics also, pediatric, you don't actually ask them to do too much of diet control. You ask them to eat everything. They're growing children. You give more insulin. Just like that, advising diet control, weight loss in children is not a good idea. Okay. Already these children are at risk for growth retardation. And just for completion's sake, anybody more than 8 years, you can actually use statins. Okay. So if at all anybody has a doubt whether statins can be given for children, the guidelines say that 8 years or more, you can give statins. Okay, not a contraindication. So identify the incorrect statement. We have around 18 MCQs. We'll speed up a little bit. Identify the incorrect statement regarding minimal change disease in children. So natural history, very important, very targeted MCQ area, frequently asked. Biopsy is not mandatory before starting steroid. Hypertension and microhematuria incidence is more than adults. 95% will achieve complete remission by 8 weeks. 75% will relapse after the first remission. What's your answer? Which is incorrect among the four? D is incorrect. B is incorrect. D. So again, we are divided. Okay. So yeah, most of you seem to think that people don't relapse. So any child less than 12 years, if it's a pure nephrotic syndrome, only proteinuria, low albumin, edema. These three things are there, nothing else. No hypertension, no RBCs in the urine, all your no extrarenal features, there's no family history, there's no syndromic feature in the child, then up to 12 years, actually a trial of steroid is indicated. You don't really want to do a biopsy. You are presuming it to be minimal change nephropathy, which is the most common cause of nephrotic syndrome in pediatric age group. So actually start steroid. So the option A is correct. Biopsy is not mandatory. And just like I just told you, hypertension and microhematuria are atypical features which are more seen in adults and not children. So that's the incorrect statement. The answer to this is B. Okay. Hypertension and microhematuria incidence is very less in children. In minimal change nephropathy, in adults, because the diagnosis may be FSGS or something else, atypical features are more common in them, not in pediatrics. And the other two statements are true, directly picked up from Harrison and very correct also. 95% will achieve remission within 8 weeks of steroid therapy, and most of them will relapse. That's the funny thing. Most of them will relapse. 3/4 of the patients will relapse, but that relapse also will be responsive to steroid. Okay, which brings us to the next question. 9-year-old boy with an SRCA. So same boy. I'm carrying over the same boy. History of steroid responsive nephrotic syndrome in 2018 at the age of 14. So these are the word you use: steroid responsive, steroid sensitive nephrotic syndrome. That's a better word to use. So guidelines would tell it as a SSNS, steroid sensitive nephrotic syndrome. Uh, with at the age of 4, with subsequent relapses, all were steroid responsive. He had many relapses, I think. Yeah. How many did he have? Yeah, 2 relapses in 2019, one in 2021, one in 2022. Intral proteinuria was absent. Investigations confirm a fifth relapse. Clinical examination unremarkable except for edema. He is normotensive. What is the ideal management? What is the ideal management? Do you want to do a renal biopsy? Do you want to do genetic testing? Do you want to start prednisolone, or do you want to switch to cyclosporin? So again, I think we are divided, isn't it? I've got all options. I've got A, B, C, D. Okay. So we'll just discuss it a little bit here. Okay. First thing that I want to tell you is, when do you call somebody? So these are the terms that you have to be familiar with. Steroid sensitive nephrotic syndrome is somebody who remits with steroid therapy, proteinuria becomes 0. Then there is steroid resistant nephrotic syndrome, where you use steroid for 8 weeks at the appropriate dose and the patient does not remit, does not achieve complete remission. We're not happy with partial. The patient has to completely remit in pediatrics. So then you call it steroid resistant. Then you have to know two terms called frequent relapser and infrequent relapser. Okay. Two terminologies that I want you to remember. So frequent relapser means they have 2 or more relapses within 6 months, that is within 6 months of disease onset, or 4 or more within 1 year. Okay, simple. 2 or more in 6 months, or 4 or more in 1 year. That is a frequent relapser. So this patient is an infrequent relapser, though he is relapsed every year, almost every year. 19 में relapse हो गया, 21 में हो गया, 22 में हो गया, but he is an infrequent relapser. Okay, he is an infrequent relapser. So infrequent relapser is anybody who relapses less frequently than this. The last term is steroid dependent nephrotic syndrome. Another thing that you have to remember: steroid dependent. Steroid dependent means you are giving them steroid, they are responding beautifully, and then when you stop steroid, within 2 weeks, if they again relapse, then it is steroid dependent. Even one episode is considered as steroid dependent. Even once, if they relapse within 2 weeks of stopping steroid, or in some regimens, when you're actually tapering the steroid, when you're going on reducing the dose of steroid and they relapse, that's also called steroid dependent nephrotic syndrome. So either during taper or within 2 weeks after stopping, if they all appropriate dose steroid, you should have given appropriate dose, then you call it as steroid dependent nephrotic syndrome. So these are terminology that you have to be familiar with. Okay, but it's very unlikely for you to get definition related. You'll get management related. Okay, so the answer here is that there are no atypical features for you to perform a renal biopsy. He's only 9 years old. He's having a steroid sensitive nephrotic syndrome. He's had 4 relapses, but everything has responded to steroid. So there is nothing off. There's nothing off. So clinical remark examination is unremarkable except edema. I put that to just tell you that there is no other odd feature like syndromic feature or anything for you to think of another systemic disease that's causing nephrotic syndrome and the boy's got lupus, nothing like that. Okay, so you wouldn't actually want to perform a renal biopsy. Okay, that's not required, it's not indicated because there is nothing off. Number two, genetic testing is also not required because he's steroid responsive. He's steroid responsive. Usually genetic mutations will cause steroid resistant nephrotic syndrome. Okay, most of 99 percentage, 100 percentage, in fact, genetic mutations will have steroid resistant nephrotic syndrome. They wouldn't have responded in the first place only. That first episode or these 4 episodes would not have responded to steroid had it been a genetic mutation. That's the important point. Genetic mutation in steroid resistant nephrotic syndrome. You would do a genetic testing then. And switching to cyclosporin is a strategy if he is a frequent relapser or a steroid dependent nephrotic syndrome. So not just CNI, you can use cyclophosphamide or you can use rituximab. Okay, you can use CNI, cyclophosphamide, or rituximab as alternate agents to steroid if the patient is a frequent relapser or a steroid dependent with the attitude of reducing the exposure to steroids. How long can you keep on giving steroids, that to high dose steroids? So, in order to spare glucocorticoid use, which are associated with side effects, you know that. So, that's why you would go to an alternate drug. So, the correct answer to this question is start prednisolone. Okay, start prednisone. I hope you understood the basic concepts of treating minimal change nephropathy. Okay, you would treat every relapse with steroid unless it is a frequent relapse or a SDNS. Okay, so you would again give prednisolone, is going to respond, and then you leave it at that. Okay, you would not perform genetic testing because he's been steroid responsive. Had he been steroid resistant, then you would have thought about it. And renal biopsy is not required because your diagnosis, suspicion of another diagnosis is not there. You're still thinking minimal change. You're still thinking minimal change. If you're thinking of something else, some new thing has occurred. For example, he is having interval proteinuria. Okay, that's why I put that line of interval proteinuria. Or if he's having any new extrarenal feature, any new abnormal lab parameter like reduced serum complements, ANA positivity, or something like that, then you would perform a renal biopsy. Okay, I hope you got it. So every relapse again start steroid. Simple. That's the message. And remember the terms: steroid sensitive, steroid resistant, steroid dependent, frequent relapser, infrequent relapser. Okay. Complete remission is when the proteinuria totally remits, and in pediatrics, you want complete remission. You're not happy with partial remission. Okay. Seventh question: 6-year-old boy with fever, coryza, and cough. History of steroid responsive nephrotic syndrome in 2021 at the age of 4, with subsequent relapses in 2022. 4 relapses. Interval proteinuria was absent. Investigations confirm complete remission. What is the ideal management? What is the ideal management? Has Fatur Rabani given the answer for this one only? Yeah, I think we were. Yeah, yeah, yeah. So everybody says C. Everybody says C. Somebody says B. Yeah. So the concept of this question, again, management questions are more common in your MCQ examinations, in SS and NEET SS. So here the concept is what should you do if a patient, because the most common trigger for a relapse is infection. Okay, that's message number one. An infection is the most common trigger for a relapse. Okay. So now this patient is a frequent relapser. We just discussed. It's a frequently relapsing nephrotic syndrome because he's had four relapses, four or more in a period of 1 year is frequent relapser. So he's a frequent relapser, but his relapses were steroid responsive. So that's a good thing. But now he's in complete remission, but he's having fever. So for frequent responders as well as steroid dependence, so the KDIGO guidelines specifically tell that only for these two populations of nephrotic syndrome, whether they are steroid dependent people or they are frequent relapses, then you would give a dose of steroid for 1 week, a course of just 1 week during the infection itself, apart from treating the infection. And the dose recommended is 0.5 mg. Okay. So apart from symptomatic management, you would give oral prednisolone 0.5 mg per kg for 5 to 7 days. That is a recommendation in the KDIGO. So that's the concept. These things are not there in Harrison actually, but you have to know important things. So oral prednisolone at 0.5 mg per kg for 1 week is what you have to give. So that's the concept. Infection is a trigger, and how do you actually deal with it? You have to prevent a relapse in these two populations by giving a short course of steroid. Number 8, 38-year-old male evaluated for mild pedal edema. The CUE is 4 plus albumin, 10 to 12 RBCs. BP is 140 to 96. Creatinine is 1.6. Potassium is 4.9. Albumin is 3.6. 24-hour protein 6.5 gram. Weight is 70 kg. USG right kidney is ectopic. It is in the pelvis. It is small in size, 62 mm only. You see only the height of the kidney in a USG report. Left kidney is pretty big, 112 or 11.2 centimeters in height. The renal biopsy was done and it shows FSGS. What is the ideal management? So from MCD, we're moving to FSGS. So the main discussion points in MCD are done. This is what you should know. So Sarthak says B, start oral tacrolimus. Nilima says C. Fatur Rabani says A. Another person says C, A. So again, we're divided. Again, we're divided. Okay. So here's what I want to give you the message. So this perhaps is the most important message that I want to give you in today's class. FSGS is not a disease anymore. Not just a disease anymore. It's just a pattern of injury. Okay. It's a pattern injury. It's a histological description of what's going on in the kidney, but what is causing the focal segmental glomerular sclerosis is more important, and that is what uh, determines the treatment. So this has been the paradigm change in nephrology over the past 2 decades, especially in FSGS. So people, the proportion of FSGS being treated with steroids has considerably reduced over the past 2 decades because of the realizations in the pathophysiological mechanisms and the causes of FSGS. So that's the most important message that I want to tell you. Okay. So this particular example, if this is actually a real patient, actually a renal biopsy itself would not have been performed. Okay. So a short word on that. A renal biopsy, when you look at relative contraindications, it's a single kidney or a single functioning kidney. Single kidney or a single functioning kidney is actually a relative contraindication. It's not an absolute contraindication, it's a relative contraindication. So here you have your patient who is having secondary hyperfiltration injury on the remaining kidney. So the remaining kidney has seems to have hypertrophy a little bit because it's compensating for the non-functioning right kidney. 62 mm kidney, non-functional, it's very small, shrunken. Any ectopic kidney is usually shrunken. Okay. And I mean, is usually non-functional. And left kidney is hypertrophied. It's having hyperfiltration injury over so many years. This is probably a congenital abnormality, this ectopic kidney. So he didn't know because he didn't have any issue. Now he's starting to develop pedal edema after 38 years. So this is a process that has happened over 38 years. And the kidney has gotten scarred due to the hyperfiltration injury. Basically, there is no immune issue. there is no autoantibody, there is no immune dysfunction, which is actually causing the disease. So you would not use immunosuppression. You would not use any form of immunosuppression. That's the message. Okay, this is not a primary focal segmental glomerulosclerosis. This is a secondary focal segmental glomerulosis due to some other issue. In this case, a reduced nephron mass. There is reduced nephron mass because there is no kidney. One kidney is not there, it's as good as not there. So the other kidney was compensating, and now it has failed after 38 years. So because there is no role for immune system, immune dysfunction here, we are not treating with immune suppression. So the correct answer to this question, without doubt, is enalapril. Okay, it is enalapril. You do AC inhibitors and ARBs, and then try to maintain his kidney for as long as possible, and then offer him a renal replacement therapy when the creatinine races to higher levels. So this is again from KDGO. This is how you have to approach FSGS. Okay, so you have a primary FSGS, you have a genetic FSGS, which is due to mutations, which can either be familial mutations, a whole family, you will have family history, many members of the family may be affected, or it could be sporadic mutation, only single fellow, or it can be syndromic. It can be syndromic. Thank you, Sarthak. I really wanted you guys to actually understand. Okay, so I'd appreciate some feedback regarding this class, and I really wanted you guys to understand about these diseases. So genetic FSGS, okay, either or it can be part of a syndrome like this of Pearson syndrome, and then secondary FSGS. Okay, secondary FSGS, where it can be due to a viral infection. Okay, which virus we'll see in the next slides. It can be drug induced, or it can be adaptive changes to glomerular hyperfiltration. What we just discussed now, reduced nephron mass, and sometimes it can be undetermined cause. Okay, so you use immunosuppression only in this category, primary FSGS. In no other form do you use steroids, at least. In some forms of genetic FSGS, you do use tacrolimus, but why the discussion is out of scope of our discussion, not required really. So in some genetic forms, they still respond to tacrolimus due to other mechanisms. So that is there, but otherwise you don't use immunosuppression to the right side of the screen. It's only primary FSGS that you use. Okay. So coming, because we talked genes, which is the most common genetic mutation associated with renal lesion of focal segmental glomerulosclerosis. Which of the following is the most common genetic mutation associated with the renal lesion of focal segmental glomerulosclerosis? I think I will exceed time today. I hope you guys don't mind. TRPC6. TRPC6. Two of you have told TRPC6. Any other question? One more question. Sorry, one more answer. What does Sarthak think? Sarthak, everybody thinks A. Okay, so this is another googly for you. Another googly. So the correct answer is C. The correct answer is C. Okay, these are little tough questions, but the point is not about getting it right now. I want you to get it right in the examination. So, Alport syndrome is the most common cause of genetic FSGS. Okay, take it from me. Most common cause of genetic FSGS is Alport syndrome. Now, if this question had the word primary podocytopathy or something like that, something signifying the word podocytopathy, primary podocytopathy, then this option is eliminated. Collagen 4 alpha 5 gene is eliminated. If the word primary podocytopathy or podocytopathy is there, then that option is eliminated, because we all know that the Alport syndrome is a problem with the glomerular basement membrane. It is a problem with the collagen type 4 alpha 5 chain is not good, so your collagen network is not good. Okay, so that's the reason. But when you have the most common genetic, because the other things are rare, your TRPC6, your actinin 4, and your NPHS1 are your podocytopathies. They have issues in the podocyte. They are genetic mutations which lead to the alteration in the slit diaphragm or the podocyte structure. Actinin, your NPHS1 is nephrin, we already discussed. TRPC6, one extra point that I want to tell you is all these are issues with the podocyte. Yes, accepted, but it's not common. It's rare. Alport syndrome, very common. Every week, one Alport syndrome I am seeing. Every week. Every 7 days, we see one Alport syndrome. So it's very common. I was very surprised after joining nephrology that Alport syndrome is so common. I never knew. So every week, one case we are seeing. So it is so common. So that's why I'm telling you that the most common, without even reading textbook, we can tell you. Once you join nephrology, without even reading textbook, you can tell that Alport syndrome is the most common cause genetic FSGS. You do a biopsy, the light microscopy will show genetic FSGS. And another class I discussed about electron microscopy, you have your basket weaving, your crisscrossing, and all those things. Okay. So the most common genetic mutation causing FSGS is Alport syndrome. So here I've put that Harrison table for you. So here you have your primary, you have your secondary, but here everything is given together. So you really don't appreciate what I told previously. Okay. Secondary, primary, secondary, genetic, undetermined cause. That's how you have to approach it. So your mutations are here. You can get some fact-based MCQs from mutations. You have your inborn errors of metabolism here towards the end. You have Fabry's disease and all that. Drugs, I want to this your attention to bisphosphonates mainly, pamidronate. Don't take analgesics too seriously. That's more associated with chronic interstitial nephritis, though it can cause FSGS. But pamidronate, the bisphosphonate, is notoriously associated with this thing. Your drugs like your that means the ecstasy and heroin, those things also. Then I want to draw your attention towards HIV. This is the most important virus that is associated with FSGS, especially your collapsing variety, your collapsing FSGS. Yes. And here you have your maladaptive response. So I've got one more slide for you. All this is there in Harrison, of course. So one more slide from KDO, where they've again split it up a little more organized manner. So you have your viral infections and recent guidelines. So they've included your coronavirus also. Yeah. Drug induced, you have so many drugs. But again, I want to draw your attention to the this thing. Oh, this list does not have your pamidronate. Very important, but pamidronate. Yeah, Hivan. Collapsing FSGS is nothing but Hivan. HIV associated nephropathy. Collapsing FSGS. Yes. But the other thing you have to remember is after the advent of antiretroviral therapy, the incidence of HIVAN has reduced much. So now you have immune complex disease, something called HIVIC. So you will see that in your Harrison also, this word, HIVIC. HIV related immune complex disease, immune complex kidney disease. That is more common now. HIVAN is less common. But HIVAN is the collapsing FSGS. So here you have your reduced nephron numbers, so you have your renal dysplasia. That was our MCQ. Somebody had a single functioning kidney, ectopic kidney, renal dysplastic kidney. So that's why he developed glomerular hypertension and his kidney failed. Okay, this is available. So this slide is anyway available in the app. This one from Harrison directly. Histological variant of FSGS associated with best renal prognosis. Histological variant of FSGS. Yeah, so everybody is getting it right. So we'll skip this question. So this usually presents like a minimal change disease itself. Tip variant. Okay. So what I want to tell you is the most common is not these varieties. There's another variety called not otherwise specified. So no features, only FSGS is there. So that is the most common variety. But you have other varieties also. Sometimes when you have cellularity, we discussed about the mesangial cell being 3 in number in a field, endothelial cell 2 in number. So all those things, when the cellularity increases, it's called the cellular variant. Then perihilar variant is there. Perihilar means near the vascular pole. So you have your glomerulus, you have a vascular pole, and you have the tubular pole. Tubular pole, and this is called the hilar pole. The vascular pole where the afferent and the efferent arteriole is entering and exiting the glomerular tuft is called the vascular or the hilar pole, and where it the glomerulus transitions into the proximal tubule. That is called the tubular pole. So this tubular pole is what is mentioned as tip. Okay. So the tip variant behaves like MCD. For some reason, it responds well to treatment. Okay. Good renal prognosis. Collapsing variant, there is collapse of the glomerular tuft. Obviously, as you have mentioned, worst prognosis. Okay, there's a collapse. And perihilar variant is very common in secondary FSGS. Any cause of secondary FSGS like your dysplastic kidney, your obesity related, your sickle cell, your reflux nephropathy, all this can have a perihilar variant that has an intermediate prognosis. Cellular has an intermediate prognosis. Okay. So tip variant, good prognosis, collapsing, bad prognosis. These two things you remember. That's enough. And secondary FSGS, perihilar variant. You can get their MCQ. What is the histological variety expected in a secondary form of FSGS due to glomerular hyperfiltration injury? Perihilar variant. Okay. So natural history, very important. I wanted to understand. Incorrect statement regarding primary FSGS. Incorrect statement regarding primary FSGS. 50% will reach ESRD within 1 decade if untreated. Steroid resistant is labeled after 24 weeks of appropriate dose of steroids. Calcineurin inhibitor is the first choice drug for steroid resistant nephrotic syndrome. 30% recurrence after renal transplantation. So we're talking about primary FSGS. So I want to start appreciating the term. So we're talking about primary FSGS, no cause. We don't know why it came. It's not a mutation. There's no secondary cause. Okay. So which of these is wrong? The answer to this question is a frequently asked MCQ. Yes. So Nilima has told B, which is the correct answer. So if untreated, Harrison also mentions that 50% will reach ESRD within 6 to 8 years. Okay, that's what Harrison mentions. And calcineurin inhibitor is the first choice. So that's why in steroid resistance, so initially you give a trial of steroid in primary FSGS for a duration of 16 weeks. So that's why option B is wrong. I mean, option B is correct, but the statement is wrong. The answer to the question is B, because the answer is 16 weeks. So you give for 16 weeks appropriate dose steroids, 1 mg per kg. And if he's not becoming remitting with that, but you accept even partial remission. In pediatric, we discussed that you want complete remission. There should be zero protein in the urine. You don't want any protein. But here, partial remission is okay. Partial remission is okay. So your albumin should have normalized and your protein should have fallen 50% of baseline to a non-nephrotic range. Okay. So calcineurin inhibitor is the first choice in steroid resistant, and 30% recurrence after renal transplantation is there. It's a notorious disease to recur. And here only you can have two more MCQs of your SUPAR level and your plasma pheresis. So the pathogenesis of FSGS, see, to put the long story short, nobody knows why these diseases come. There are so many theories, that's all. But anyway, there seems to be the circulating factor which is responsible for FSGS. But on a routine basis, we don't find any circulating factor. So it is not a part of any recommendation to check all this SUPAR. But post-transplant, when it recurs, we usually tend to see the SUPAR levels, which is not commonly available. We'll have to send it to Delhi and Bombay and all that. And you can do a plasma pheresis to remove this SUPAR so that the FSGS will remit. Okay. So post-transplant recurrence of FSGS is treated with plasma pheresis. That is the message. Okay. Post-transplant recurrence of FSGS is treated with plasma pheresis. That is an MCQ. And number two, plasma pheresis basically means you are removing plasma and then giving new plasma to the patient. Okay. You are removing plasma from the patient because there is some antibody which you want to remove. And that antibody is SUPAR in this case. That's what I wanted to remember. Question number 12. 62-year-old male is evaluated for progressive pedal edema over 30 days. CUE is 4 plus albumin, very few RBCs. BP is normal, creatinine is normal, albumin is very low. 24-hour urine protein very high. Serum M-type phospholipase A2 receptor antibody is 55 international units per ml, detected by ELISA method. Which of the following is not required in the management? Predator says DA. Is it D or A? A. Okay. Predator says A. Fatur Rabani says C. Eliciting history of native medications or NSAID. So we've come to the third disease that we're going to discuss mainly today. So the three main causes of nephrotic syndrome clinically are MCD, FSGS, and membranous nephropathy. So we're coming to membranous nephropathy. Okay, so I believe that I've discussed MCD and FSGS to good detail, consider whatever is required for you, even for any SS level, to be frank. And membranous nephropathy is what we discuss. So diagnosis is very clear. Okay, so this is the method that we commonly use. This is the ELISA method. Actually, there is a Western blot method, which is the most sensitive, but not commercially available. Then you have your immunofluorescence method, which is more sensitive than ELISA, but again, not commonly available. Only in some laboratories it is there, where you get actually positive negative results. And then you have your ELISA method, in which the cutoff, as per KDIGO guidelines and all the laboratories, is 14 international units per ml. Less than 2 is negative, 2 to 14 is equivocal, and more than 14 is considered positive for membranous nephropathy. So that is again a landmark change in membranous nephropathy, that actually you don't require a renal biopsy to actually establish the diagnosis of membranous nephropathy. So it is a very robust biomarker. It is a very robust biomarker, this PLA2R. So if PLA2R is positive, you can be sure that the histological diagnosis is membranous nephropathy. But then again, I want to tell you that 70% of the cases where your membranous nephropathy is coming without cause, the so-called idiopathic membranous nephropathy, this thing will be associated. But that doesn't mean that if PLA2R is positive, it is always idiopathic. That is the message I want to give you. Okay, two things. One thing is, it is a good biomarker, so you don't really have to do a biopsy. So let's get it straight. This is the correct answer. Predator was right. A is the correct answer. Performing a kidney biopsy to confirm the diagnosis is not required when the PLA2R is positive. It is not required. Okay. But just because PLA2R is positive, it does not mean that it is idiopathic. That is the second message that I want to tell you. Just because PLA2R is positive does not mean that it is idiopathic. There may be a secondary cause of membranous nephropathy still at work. So option B, option C, and option D are related to that. They are the secondary causes of membranous nephropathy. Cancers, your native medications, especially those that contain mercury. Okay, that day in one class, I was telling you about another biomarker, NEL1, isn't it? So this mercury containing native medications, you will have NEL1 as the antigen instead of PLA2R. And we also discussed about thrombospondin. That day I was telling you. And serology for the viral. These three viruses are also associated with membranous. HIV, HCV, HBV. Most commonly, you are HBV. Hepatitis B virus is more commonly associated with membranous. Hepatitis C more commonly with membranoproliferative. That's another MCQ. Okay, so that's the message. So this is from the KDIGO guidelines. A kidney biopsy is not required to confirm in a patient with nephrotic syndrome and a positive antibody test. Okay, so though the kidney biopsy is gold standard, when it is a good biomarker that can establish the diagnosis of MN with high accuracy without the associated risk of biopsy. So chapter close. Next thing, this is again from KDIGO. You have secondary causes. Just for that, I put it. Okay, secondary causes are there. So I want to draw your attention to the footnote. Okay, just see the footnote. Figure 29, evaluation of patient with MN for associated condition. Patient with MN should be evaluated for associated condition independent of the presence or absence of antibody, either PLAR or TSHD, thrombospondin. You have to assess them for secondaries. This is what we do for any patient who comes with membranous nephropathy. We just sit back, just look. We don't make them do all the test. We don't make them do all the test, but we take good history, viral markers anyway we do, and anti-nuclear antibodies we do to look for secondary cause. It may be lupus nephritis, who knows? Class 5 is membranous nephropathy, isn't it? And we see for it, we do a full clinical exam and age specific cancer screening. For example, this patient is 62 years old, so I would do a chest x-ray. I would inquire him about his bowel habits. I would look for any anemia and then probably consider an endoscopy or a colonoscopy. And then I would do a prostate specific antigen as well. So age specific cancer screening. With a female, I would do a mammogram or at least a breast examination, or an ultrasound, high resolution ultrasound or a mammogram, and I would do a pap smear. Yeah. So those are the things that I mean. Which of the following histological findings points to a diagnosis of a secondary membranous nephropathy? Just because we discussed about lupus nephritis, being classified lupus nephritis is membranous. So, which of these following histological findings actually tips it in favor of secondary membranous? Do we have answers? A. Yes, so Fatur Rabani is correct. The presence of subendothelial deposits tips it in favor of lupus. So this is a direct line from Harrison only. Also, they give the word tubulo reticular inclusions, TRIs. Okay, this is seen only in electron microscopy. All this seen in electron microscope. Option A, electron microscopy. Option B, electron microscopy, where that is the finding in membranous, primary membranous itself. This is the immunofluorescence finding. This is another MCQ. That's why I put it as an option. This question I got when I wrote the exam. Which class of IgG is there in primary membranous nephropathy? In primary or idiopathic membranous nephropathy, what is the class of IgG? So as you all know, there are four classes IgG, IgG 1, 2, 3, 4. So in primary or idiopathic membranous nephropathy, the class of IgG is IgG4. It's there in a small part of Harrison. It's hidden, okay, basically. And presence of uniformly thickened GBM is the prototype feature. Which of the following malignancies most likely associated? So secondary causes, especially when you have an old age person, you are thinking of cancer, 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 cancer. So what is the cancer? Hodgkin disease, Burkitt lymphoma, breast carcinoma, malignant melanoma. Which is the cancer that is most likely associated? So see, so everybody are clear about that. So the concept is solid organ tumors. Solid organ tumors are more associated. So Hodgkin's is also associated, MCD. Okay. Burkitt is special because spontaneous tumor lysis syndrome is very common in Burkitt lymphoma. It's a high tumor burden syndrome. Sometimes before treatment, usually tumor lysis syndrome diagnosed by the Cairo Bishop criteria. Yes, we discussed that, I think. It usually happens after starting treatment. So in Burkitt lymphoma, spontaneous can occur. That's a special thing. Malignant melanoma, again, this is one of the most common. Skin cancers are very common in dialysis patients and post-transplant patients if they live long. So the answer is breast cancer. Solid organ tumors like breast or colorectal are more associated with membranous nephropathy. So this is a table from Harrison. We've covered it in good detail. I'd like to draw your attention to two, three things. Come to drugs, gold, mercury. Mercury, I told you, NEL1, penicillamine. Three things I want you to remember. Then here you have your breast, colon, lung. So you can see that all solid organ tumors. And then infections, I told you, B is most important. Yeah, other things are also there. And then autoimmune disease, SLE, remember SLE. Okay, that's the most important thing that you have to remember. Other things are there. Okay, but that kind of MCQs I don't think we'll get. Which of the following is least consistent with natural history? Again, I told you natural history, very important. If I am the question setter, compulsory, I'll keep asking you these things only. So ABCD, 80% present with nephrotic range proteinuria, 30% have spontaneous remission without treatment itself, high incidence of venous thromboembolism, titers of antibody. So Nilima says A. Can you type why Nilima? Can you tell me why? Can Nilima or Fatur just type in the chat box why you tell A? Then I'll be happy. Oh, because you think it's 100%. What about Nilima? Why do you think? High incidence of venous, option D is titers of antibodies correlate with disease activity. That's option D. Least consistent. Okay, so everybody are stuck with percentages. 80 is correct. Okay, 80 is correct. This number is from Harrison only. But the thing, this is what in the first slide I had told you, no. In the first slide I had told you. No, no, there's one more thing. Harjot and everybody, just listen. In your MCQ questions, nobody is going to test up to 5%, 10% and all. Okay, nobody will say whether it is 70 or grossly they will give you some number. Okay, so you will easily be able to tell whether it is correct or wrong. It's very depends on the question again, but these kind of questions you don't have 70, 80, 85, that kind of number twist they won't give. So the twist here is nephrotic range. The first slide we told about three terminologies: nephrotic syndrome, nephrotic range proteinuria, and non-nephrotic range proteinuria. In nephrotic range proteinuria, what did I tell? You have more protein, but the albumin is normal and edema is minimal. That is not the case with membranous nephropathy at all. Your albumin will be low. It is a nephrotic syndrome. That's the answer. Yeah, Fatur. Now you got it right. So it presents as nephrotic syndrome. Not that your patient will be bloated up. That concept also you should take away from your head. So we tell a patient has nephrotic syndrome if he has more than 3.5 gram proteinuria and low albumin. That's it. He may or may not have edema. He may or may not have lipiduria. He may not have altered lipid profile. So that those are not essential things to diagnose nephrotic syndrome. Only two things: albumin low, protein high, nephrotic syndrome. So that's what membranous nephropathy does. It's not a non-nephrotic. I mean, it's not a nephrotic range proteinuria. You never see, it's very unlikely. That's less common. Only 20% will present like nephrotic range proteinuria. 80% will have nephrotic syndrome. I hope you got the concept right. And one more thing I'm telling you, in MCQs, don't be worried about the numbers. They're not going to check numbers like that because it's not about learning by rote or by heart. No, how many numbers can you actually grossly you have to remember? Grossly, what is more common, what is less common? Okay, there are some things where percentages become very important, but not to the tune of 5 or 10 and all. Okay, so membranous nephropathy completed. Last 2 3 questions. Diabetic nephropathy. So introduction, it is the most common. All those simple MCQs आपको आ जाएगा. There's no doubt about that. You will be able to crack all those. Certain points I want to tell you. 56-year-old female with type 2 diabetes mellitus since 20 years is found to have creatinine of 1.5, albumin of 3.7, CUE of 3 plus albumin, no RBCs, some pus cells are there, significant. 24-hour urine protein is nephrotic. Yeah. So now see, this is nephrotic range proteinuria. Okay, because the albumin is normal. Okay, that's what I wanted to tell. Okay, somebody has asked me a doubt. So somebody has asked me, is in lupus? Yeah, so in lupus nephritis class 5, you will have both. You will have both subepithelial deposits and subendothelial deposits. So that's the doubt they had. Okay. So somebody's asked me, Celine has asked me whether the deposits will be subepithelial or subendothelial in class 5 lupus. You will have both. That's the difference. Whereas if it is a pure membranous, idiopathic membranous nephropathy, you would have only subepithelial. You wouldn't have subendothelial. Okay, that's clear. So Fatur Rabani says C, correct answer. So simple question. That's what I want to tell you. So one I wanted to highlight that this is nephrotic range proteinuria. You have your normal albumin. Okay, that's a frequent scenario. Nephrotic range proteinuria. Be familiar with that. Different from nephrotic syndrome. So 40% will develop nephropathy is correct. These days, we are noticing that many of the patients with CKD and diabetes are having non-proteinuric kidney disease also due to microvascular ischemia. So that fact has been taken note in Harrison. So I will have to go back and check the previous Harrisons. But as far as I remember, I think this point was not there in previous Harrisons. I will go and check today. You also check and tell me. Okay. But I think this line was not there in Harrison previously, probably 19th and 20th editions. So 50% patients are normoalbuminic. That is also there. And this is the point. So this is a very frequently asked MCQ point. More than 90% patients of type 1 diabetes have concordant retinopathy and nephropathy, whereas only 50 to 60% of patients. In Harrison, the number is 60 of type 2 DM will have retinopathy. So just because retinopathy is not there, you cannot rule out nephropathy. That's the message. And this is one of the diseases where until advanced CKD, when usually you expect other diseases to have shrunken kidneys, you will have normal or bulky kidneys. So infiltrative diseases like amyloid, your HIV associated nephropathy, and diabetes nephropathy. These are the three commonly mentioned causes for large kidneys with advanced kidney disease. So image-based question, if at all they are going to ask you in diabetic nephropathy, it is going to be from diabetic nephropathy. And ADPKD also has large kidneys, but then that is cysts. Okay, so that's a little different. Here, the kidneys are looking normal, but normal size. So that's not the ADPKD, you cannot consider that way. So yes, everybody gets it right. So nodular glomerular sclerosis or your Kimmelstein-Wilson lesion. Okay. So this kind of thing you can, you have a nodule here, it's pretty self-explanatory. Usually it is seen in the periphery of the glomerular tuft, some extra points. Periphery of the glomerular tuft, just like in this image. So I chose an image from Google so that I can tell this point to you. Periphery of the glomerular tuft only, you will usually see this nodular. It will first appear in the periphery and it will be away from the vascular pole. It will be towards the tubular pole. That is also there. Two special points. So that's an image question. And one more frequently asked MCQ thing. This is also very frequently asked concept in diabetic kidney disease. Inhibition of the renin angiotensin aldosterone system is least beneficial in which category of diabetic kidney disease? I think this is the last question, so I'm not going to take much more time. Least beneficial in which category? A. Faturamanis is A. A. So everybody are clear about that. Okay. So the message that I want to tell you is any diabetic with high BP, okay, you start them on an AC inhibitor or ARB only. That is a first choice drug. So you're hypertensive, but normoalbumin. There is no albuminuria, but only hypertension. You would still consider your ACE-ARB. This may be another MCQ. That's why I'm telling you this point. You still prefer the ACE-ARB as the first choice. It is there in guidelines. Okay. This is the first choice antihypertensive in a diabetic, even if there is no proteinuria. And whenever there is proteinuria, then there is no doubt. One more thing is this term called micro and macro has been taken off. That's also mentioned in Harrison. So it's called moderately elevated and severely increased, moderately increased, and severely increased albuminuria. That is a new terminology, just terminology thing. So anybody with no normal BP and no proteinuria, there is no benefit. So this can be another MCQ. I mean, precisely this one. Is there a benefit of adding ACA and ARB if there is normal BP and no proteinuria? No benefit. Okay. As of now, no study has shown like that. So we will tomorrow, if all things, one thing that I want to tell you is, as you know, as you would have guessed by now, that most of the faculty, not most, all the faculty who are taking classes for you on this 100 days Harrison are working residents, including me. I'm a final year nephrology postgraduate. So sometimes there are alterations in schedule. So apologies in advance for that. Yesterday I couldn't take class because my colleague was sick and I had to take over the duty. So such things may happen. Please bear with us. Okay. But rest, I can assure you that no class will be missed. Okay, no class will be missed, and all the classes will be taken. And just like most of you prefer to see it later on in the app, everything will be recorded and put. So in case I'm not able to take also, I'll record it in the middle of the night and put it on the app. And we're very happy that more than 250 people have joined. So please share it with your friends also, so that many of them can get benefit. If you think it's good, please make sure you share it with your friends. We have one more doubt. We have one more doubt. I have a patient with membranous nephropathy with normal and very high 24-hour rate. That is because it is a non-selective proteinuria. So only in minimal change disease, you have almost all the protein that is excreted is albumin. More than 80% will be albumin. Okay. In other proteins, since there is non-selective proteinuria, you can have such reports. But that said, I am very surprised that the patient has normal UACR. You will have to repeat that test. That particular report I will not trust. Okay, normal UACR is a little too much. You can have less of it, but not normal. Yeah. So that is one thing. So we will continue tomorrow if all goes well. Tomorrow I'll meet you again. Why will HIV associated kidneys have normal size? Unknown reason, to be very frank. Okay, unknown reason. Amyloid, infiltrative, even diabetes, we don't know why it's normal size, why it doesn't get shrunken for the same. One more question: is fenestration slit and slit diaphragm same? No, 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 no. Fenestration is in the endothelial cell, the capillary lining of the capillaries. No, lining of the capillary endothelium may fenestrations are there. Usually capillary endothelium does not have fenestration anywhere else in the body. Only very few sites have fenestrations, and kidney is one of those sites. Okay. I did read that some parts of the bowel and some parts of the pancreas also have fenestrated capillaries, but largely they are not fenestrators. That's special point. And slit diaphragm is the connections between the podocyte food process. Okay, so they are totally different things. Totally different things. And regarding the Harrison, in Fihali, they have given fenestration slit 30 to 40. I will verify that and put it back on the. I'll probably personally mail you Fatur Rabbani. There's some confusion in that probably. Okay, yeah. So, and one more thing, line by line, Harrison, I have made it into an MCQ in the Surgtest app. Okay, because sometimes in your NEET SS, you may not get questions like all your questions may not be like this. So some of the questions will be like this. Some of the others will be just like full tosses. I told you that very simple factual based questions. So those things and all line by line I've made Harrison MCQ, so you can subscribe to the NEET SS medicine or nephrology MCQ bank for that. And if you are taking part in NEET SS also, I have made Fihali into notes and put it as high yield notes, so you can try that out as well. And thank you, I'm glad all of you liked it. Thank you.